would like to call Dr. Virupaksha Bishwas, MBBS, MD, clinical and interventional pathologist with a special interest in hepatology, hematology, geriatric medicine, and critical care medicine from India to give a valuable speech on a systematic discussion on pancreatic neoplasias in all age groups and exhaustive appraisal of diagnostic stratification, histopathologic pathogen, and the multimodal oncotherapeutic spectrum based on 13 high-end studies.
Thank you. Thank you, Andrea. Can I share my screen?
Yes, sure, doctor.
Yeah. Can you see my screen? Hello? Can you see my screen?
No, doctor, we can't see your presentation.
That's the problem. I've shared. Hold on. Yeah. Now? Can you see my screen?
Yes, doctor, we can see your screen.
Great.
Would you please
Great.
share?
Yeah.
Yes, doctor.
All right.
We can see
Yeah.
your presentation. Yes.
Right away. So this is how we go. Thank you, Andrea, for allowing me to talk. I will straight away go into the topic. It's about PDAC, Pancreatic Ductal Adenocarcinoma. And this is why I have taken the topic. I have taken 13 studies, very high-end and impactful studies, to decode what is it, and what are the problems and challenges that we're going to face regarding this particular variant of pancreatic neoplasia. There are other variants as well, but this particular variant is of high importance. I've added a slide out here. You can just go through the slide. Why is PDAC so important in today's day? It's because the 5-year survival in 2026, despite such accelerations and upliftments in oncotherapeutics, we still have it less than 10%. That's the problem. The second point, rather, the global 5-year survival remains below 10% despite therapeutic evolution. We have had wonderful evolutions. We have integrated AI as well. People are working on CAR T cells. People are working on stem cells. But still, it is below 10%, the overall 5-year survival rate. That is why I picked up this particular topic. Right. So you can see, pancreatic oncology is not. It's no longer merely about detecting tumors. It's about decoding the biology. Why has this happened, despite a colossal evolution? I'll go to my next slide. It's a global burden. The 7th leading cause of global cancer mortality. And when I have seen patients of pancreatic cancer, when I see them, you see they usually come with painless jaundice, weight loss. Some may or may not have a back pain, may or may not have, will have anorexia, of course. These are non-specific, and will have a weight loss. Still is non-specific. This is one part which everybody should remember when they would evaluate a PDAC patient. That the basic clinical features are going to mimic a lot of diseases. That's the biggest problem. So we'll have a lot of DDs in that case. Don't waste much time out here. I'll be discussing one by one. I'll be discussing all the issues one by one. Like we have KRAS mutation, a T53, CDK2A, and SMART4. So I'll be discussing all of them. What's the exact mutations that do happen? You can see in this slide the median survival in a metastatic disease, in a TNM staging rather, if we have a M1. is historically less than 1 year, even still up to date. Right? So this is how a tumor progresses. We have precursor lesions. This is why I have made this. Particular slide so that you try to understand where are the places where we need to intervene or we can intervene. Though in my practice or in any practice whatsoever, you see that almost 90 to 95% patients, they actually present very late. You can see the evolution, the tumor mass and the dysplasia increase. Of course, you'll have metaplasia, you'll have dysplasia, you're going to have carcinoma in situ, then you're going to have a frank carcinoma. So again, initial lesions. Initially, you're having a KRAS mutation, which is then accentuated by CDK2A. Then you have a T53 loss. This is the biggest part, and a SMART4 deletion for meds. It's very much there on the slide. So initially, the driver for PDAC is KRAS. So we can work here. This can be a checkpoint. This too can be a checkpoint. In fact, all of them can be checkpoints, not beyond this. Once it has gotten to this portion, it has spread all throughout the body. There you're going to have problems. At that point of time, you have nothing rather than neoadjuvant chemotherapy. I'm going to discuss that. This is the molecular taxonomy. I've given a slide out here, cytology-based slide where you're going to have, these are the major pancreatic neoplasms basically, a ductal adenocarcinoma, which we are discussing right now. NETs are very important, happens in babies actually, the pediatric age group. Some intraductal papillary mucinous neoplasms, mucinous cystic, solid pseudopapillary, and acinus and carcinoma. These are basically, some variants that usually happen. As far as the histologic hallmarks are there, I have a picture. I'm going to show that. There are molecular subtypes. You can see squamous, pancreatic, progenitor subtype, immunogenic subtype, and AEDX subtype. Now, biomarkers. This is a place which becomes important, at least in the developing countries. We can go for biomarkers. You can see as to which biomarkers are important. Let me tell you, KRAS, I have discussed it, is very important. Now, if I come to MSI-phenotype, it's microsatellite instability. Of course, we can even go for that. There are certain biomarkers. I'll discuss about that. If you go for BRCA1, BRCA2, this is one biomarker for pancreatic cancer. It's usually known for breast cancer, some lymphomas, for, say, for example, some other tumor, usually for breast cancer. But in this case, we also do have that. We can put a hands on for the POLO trial, which I'll be discussing. If we did find out the BRCA1, BRCA2, they also do have their mutations. And DAX and ATRX has been discussed for the neuroendocrine variant, the PANNET biology. This is a standard slide of a patient with PDAC. So you can see what are the things that we need to appreciate out here. We can appreciate this portion. We can appreciate the glands out here, all the glands. You can see this glands, they have all the hallmarks which define neoplasia per se. Bizarre glands, all absolutely bizarre. They differ in their sizes, in their presentation. What we need to understand out here, that you can check that this is metastasized. It's there. It has also turned up around a neuron as well. Plus, there is lymphovascular permeation for this. Now, this portion needs to be appreciated. The dense desmoplastic stroma. This I will be discussing on later on my later slides. That how this is going to affect the entire chemotherapy for patients per se. This becomes very important. Just look at the dense desmoplastic stroma. Desmoplasia is just a reaction where excessive of fibroblasts coming around and there's extensive fibrosis. This will actually stop the drugs that we usually give this patient from penetrating into the tissue. I'll be discussing that in my next slides. See, these are some of the modalities in which we can detect pancreatic cancer. Number one is a triphasic MDCT. We have 3 phases out here: a delayed venous phase, arterial phase, and phase of washout or equilibria phase. And this is an excellent imaging modality for lesions greater than 2 centimeter, not for lesions which are less than 2 centimeter. MRCP, MRI, yes, they do have a good sensitivity, of course. When you go for EUS, endoscopic ultrasound with the FNA or FNB, with the final aspiration from the particular lesion, the diagnostic accuracy for this particular part will remain for around 84 to 95% as far as my experience is concerned. It depends on how much tissue we can bring out from that part, or how much tissue yield we get. That becomes very important. When you come for functional imaging, you can see FDG, fluorodeoxy, glucose PET CT, and 60 Dotodec for NET tumors, neuroendocrine tumors. And there are some emerging diagnostics as well, such as circulating DNA, such as AI-based genomics. I'll be discussing this part because it's an AI conference as well. We have integrated AI into this conference. You have confocal laser endomicroscopy. So these are certain ways in which you can, and rather these are the best of the lot, the ways in which you can make a proper diagnosis. I would rather go for a EUS endoscopy ultrasound with the FNA or FNB, or a triphasic MDCT. That's what we usually go for. And we have those facilities out there in West Bengal. So that's how it is in Calcutta. And we also have a PTCT, both of them rather. Okay, put a picture out here. It's a triphasic, a delayed arterial, a venous phase, and a phase of equilibria. You can easily detect the lesion out here in the pancreas. You can see there's, I've pointed the laser out here. Can you see the laser? Would you please appreciate the laser? Hello? Hello? Miss Andrea, hello? Hello? I'm marking the part, the head of the pancreas. You can easily see that. This is a
Hello?
Yeah, you can see
Sorry
the laser.
for the inconvenience, doctor.
You can see the laser.
Yes, doctor.
Yeah. Thank you. So the next one is an MRCP and MRI and MRCP. So this is very standard one. This is how we go for a EUS probe. We use a EUS probe to kind of get the lesion. The endoscopic ultrasound. Endoscopic ultrasound plus minus FNA. Of course, plus FNA. It's not going to be minus. You're going to get a whole tissue sample. And this is the Dotodec scanning. The Dotodec scanning, the PET CT cover. This is the lesion out here at the head of the pancreas. You see this. These are 4 images that I placed. Okay, so this is where we come to the actual part of the entire problem. So, what brought about the revolution? It was the FOLFIRINOX revolution. When we did combine 5 fluorouracil, leucovorin, iron-octane, and oxaliplatin. The FOLFIRINOX revolution. The median OS, the median overall survival was it is clocking to 1 year. But this particular regimen is suited for patients with a preserved ECOG status. Who has got a good functional status around. Now let's go to the next one. So let me just discuss about neoadjuvant therapy. These are for resectable diseases. You have a tumor, in simple words, you decrease the size of the tumor and then you resect the tumor. Bring it to unknot. I've written out here in my second point, second bullet. You have a patient with a tumor, decrease the size, then you cut it off. For frail patients with a somewhat ECOG status clocking around 2 to 3, we have gemcitabine plus nab-paclitaxel. Let me just talk a little bit on nab-paclitaxel. It's basically paclitaxel, which is bound to a nanoparticle coated with albumin. It's a very recent method. It's not usually practiced in and around India, but then fine. Outside, of course, there are cases where this particular regimen is practiced for patients with an ECOG status within 2-3, of course. Actually, the ECOG status usually helps us to determine the functional state of the patient, the functional part of the patient, how the patient behaves with the neoplasia. Can he carry out his daily duties and his work, or he's totally failed out? If I speak about adjuvant, I had spoken this earlier. Where do we use adjuvant therapy? Where you use gemcitabine plus capecitabine. Where do you use that? When the tumor is not resectable at all, or maybe post-surgery at times. Written here post-surgery, but then when the tumor is not resectable, it's better to go for gemcitabine plus capecitabine. Please remember this point because I'm going to show this on a Kaplan-Meier analysis curve in my next slides. Okay, I've just formulated a clinical decision tree. Let's discuss this in slight detail. So we first check the ECOG status. That can the tumor be operated or it cannot be, in one line. So if it is borderline resectable, we'll use neoadjuvant, we'll bring it down, we'll shrink down the tumor, and we are going for the surgery straight away. Is there? Now, if you go for advanced disease, just forget about this part. We can assess the fitness of the patient and we can think about it. So if it's a fit patient with a preserved ECOG status, say clocks at around 1, we use the FOLFIRINOX regimen, the median survival improves. But if it's a failed patient, we can use gemcitabine plus nab-paclitaxel as discussed. This is the algorithm, rather. But if it's an advanced disease, we usually go for a biologic control. I'll discuss about this part, what we do. Basically, what we do, we go for a palliative care or an end-of-life care. That's where we push the patient, and that's very usual practice outside the country, outside India, I believe, where they usually push the patient